I've just asked the question, how many people do we expect to die in Italy from a deadly flu virus? And to answer that kind of question, we go to the literature and we say, well, if this is worse than the seasonal flu, we could take a look at the seasonal flu and we'd say COVID would be at least as bad as the seasonal flu. And there's these two flu seasons, 2016, 2017, 2013, 2014, that killed 10 times as many people in Italy as COVID. Maybe COVID isn't so deadly after all.
Well, I think there's several problems there. This is towards the tail end of the normal flu season. So the appropriate comparison would be, what is the fatality rate from flu or other things that affect the vulnerable populations? You could also look at it by looking at patients who are not from the, don't simply meet the age demographics, but have other comorbidities. So these are people who, so you're coming back and saying, people might be vulnerable due to a variety of reasons to a variety of vectors in the world, but they will be, in this case, are they vulnerable to the specific factors that are significant in this form of respiratory illness? Second is, I think all of these things of playing around with looking for different baselines miss the point that we have something that is, I think this plays into what we've talked about before about what's novel. Right. What kinds of actions can you take? And so when you have something new, there's a responsibility to say, okay, what can I do? What can we do, hospital, region, jurisdiction, society, to address the particular threat that poses, and not to simply say, so many people die from traffic accidents, therefore it's okay if they die from this.
Not at all comparable. Right. That's a bunch of crap. Yep. Yeah.
Unethical, crazy talk. So we have to look at it in the space of adaptive capabilities to deal with things that are happening. And I did look through the article, didn't go study it carefully, but my immediate reaction was, this indicates to me that the elderly population in Italy has some basic vulnerabilities. Now, that doesn't make me less worried when you take an area like the US with its spotty healthcare coverage, with many comorbidities widespread in the population, morbid obesity, type 2 diabetes, chronic heart disease, COPD. We have a whole bunch of different factors that go on. Now, maybe the way we care for our elderly in parts of our society make it easier to isolate them and defend them. There's many, many other kinds of factors that are going to play out in how the mortality statistics, anything, I think that starts to come back and builds, allows for rationalizations of complacency, and we don't need to act, we don't need to think, we don't need to intervene, we don't need to change things. I can still go to Disney World or spring break, is, I think, crazy talk. I mean, this is putting people in danger.
I disagree. We're going to talk then about crazy talk. And we're going to get there the long way. The resilience question is, how do you know when you are faced with novelty? That's the general question. The specific question is, what is novel about this infection? How do we know that this one is novel? That's not a crazy question. You might answer it and then say any other answer is crazy, but the question applies. How do we know when you're faced with novelty, and how do we know that this infection is novel?
All right, it's a surprise to your model for how care can happen when in emergency medicine, when things scale, right? When challenges go up, when surges happen at some scale. The standard resources, the standard way, the capability of a place, right, turns out not to quite be the capability it really has. to handle various kinds of challenges, some of which are understood a little bit, but misunderstood in a part, or just not understood completely. Not all of the factors that go into it play out. This is where we look at some emergency plans and go, they have significant fiction, or they are tremendously underspecified to how the challenges happen. So on the one hand, the novelty here is that the world is forcing you to recognize the limits of your plans. The world is forcing you to dig into the normal mechanisms of adaptation at the boundaries, at the edges of your planful, the way things are expected to be able to work.
What does that forcing look like?
Breaking down. And now you have to do something different.
When the world is forcing me to do something different, how do I know that I'm being forced by the world to do something different? What would show up in my life or in my data, or, I mean, where I would look at it and be like, wow, that's different.
Well, that's why we look at the gap between work is imagined from distant perspectives and work is actually done in real settings at real front lines.
And there's always a difference there. But in this case, what should I be looking at that tells me, aha, this is different. My plans are inadequate. I am going to be overwhelmed.
Right, so can I try?
Yeah.
Yeah.
So just while you were talking, I was poking around, and it turns out today there's an NPR article that I just pushed to you.
It looks great.
All the ways in which novel coronavirus and the flu are alike and different, right? And so it goes through all these dimensions, right? Symptoms, transmission rates, right? Fraction of mild versus severe cases, length of hospital stay, what percentage, will require hospitalization, death rates, these kinds of things, right? So in some sense, right, Tom, I can understand that you would say, well, I can use the same set of parameters to characterize the novel coronavirus as I can the regular flu, right? This seems like this is not completely novel because I have places to fill out these numbers and these values, right?
Mm-hmm.
But what I think that David's getting at, right, and at least the story that I'm telling myself in my mind is that you look at the cumulative effect of some of these, right? So there's a larger fraction of people that are going to require hospitalization. Okay, fine, right? There is a survival rate for the coronavirus, provided that you can get the adequate care in the hospital, right? That you can get onto a ventilator, that you can, right? And so when you compare those rates to kind of normal flu, then it's like, well, the coronavirus isn't that much worse, right? Because that survival rate's, still pretty good. But when you put these two things together, right, suddenly you run out of ICU units, you run out of ventilators. And so the actual death rate that you experience is not the one that is kind of with an assumed availability of respirators and everything else. It's in the absence of this care. And so the rate at which you might experience it is much, much higher than the rate at which, nominally on paper, this is what's being measured, right? And so it's these compounding effects that I think are, at least in terms of what I'm hearing, is causing your system and your plans to be stressed in ways that you want, right? It's sort of like, yes, the county has a disaster plan that assumes that all the other nearby counties are available to provide support, right? And so when something happens and everybody has a disaster, right, none of the disaster plans are sort of working, right? And it's sort of this compounding. And
that makes sense to me.
That may be
Tom,
oversimplification.
I really want to come back and say this one's easy, right? And it demonstrates all of the kinds of things we talk about. First off, it's called a novel virus. It's new. Ooh, start from the beginning. Oh, we now have infections in human population of a new virus we haven't seen before. That's novel by definition from the get-go. Easy. Right? And the first rationalization, it's just a problem those people have, not me. Second, right? We've had a variety of exercises relative to pandemic issues. What's that? How to, instead of having a local epidemic or a local surge, as Dave just pointed out, and what happens there, this is what happens when we have an epidemic or surge that covers multiple jurisdictions simultaneously or nearly simultaneously in time. In other words, what happens if these things scale up and cover regions and continents and so forth? And the answer there, when we do simulations and we do dry runs and we do practices, is, it's pretty quick to say we don't scale up very well. 3, right? We have the experience with other threatening new infections, new infectious diseases, H1N1, Ebola. All of these have parameters that create some self-limiting conditions. Partly they're too lethal. And so from a straight infectious disease point of view, having these parameters that allow us to understand transmittability and lethality and some other kinds of things, we know something about what does it mean to intervene and interdict the spread of this stuff, right? By the way, another dimension of novel I should have mentioned in the first batch is it's novel. Why? We don't have a way to directly treat it. We don't know which drugs are effective. It's a virus, but what drugs or variations are going to be effective in this relative to other possibilities? We have built up some degree of an arsenal in recent years on antivirals, in part driven by HIV. But where and how is it going to work against this new virus? Right? We don't know. We are outside the bounds of what we have known and understood in the way to treat things that were also at one point new, that forced us to rethink, remodel, expand our repertoire of responses. All of the evidence, as comes back from people who have experience, for example, with Ebola, is warning after warning that we're not prepared. If one hits, if a new infectious disease has a different set of parameters that makes it more transmittable, easier to infect other parties, yet still sufficient lethality that it represents a new kind of threat to people on a widespread basis, we are not prepared. So the novelty is, in all of this stuff, is a mismatch between challenge and response capability. Right. So the issue here is we have gone through this. I sent it today. Right. The fundamental issue in decompensation is the process of, no matter what scale we look at it, is a fundamental way adaptive systems break down, is the compensatory mechanisms are in play as a disturbance grows and strengthens and spreads. And so that compensation for the building challenge makes it look like everything's on track. It looks like things are only slightly off kilter, slightly behind, not too threatening yet. And then you have a rapid surge of challenge that don't have the readiness to respond to meet, and there's a rapid follow-up.
What number of hospitalizations in your state would concern you, where you point to that number and you say, holy crap, decompensation right here, right now?
Well, the problem is, but as soon as you have a decompensation, you're already too late.
I understand, but what number?
This isn't novel or whatever. We have 2 places whose fatality rates are much higher than other places who have responded to the same novel virus and the mismatches it creates. Wuhan, because they were the first, and Italy, really the first.
Spain looks bad now too.
Oh, excuse me?
About 1,000 people now dead in Spain. It looks very bad. Yep. Right?
And I sent you the quote from the guy in Spain. But all of these have this quality of slowly building and then a rapid rush on that they're not really prepared to deal with. They have to institute reactive measures to try to cut transmission rate, reactive measures try to build capacity to treat the seriously ill people. They are falling behind in the care, and the measure of that is the difficulty it took to resolve that, and the strength of the shutdowns that had to go on, right? And the reports from the front lines in the hospitals in these places of we're on the verge of collapse, even though
Dave,
it is
right now,
effective.
there are hundreds of thousands of people in the state of Ohio infected with COVID. 39 of them have required hospitalization.
Can I try, Tom?
Yes.
So one of the things that David has studied over and over and over again in these patterns in the way that systems fail. And one of the common patterns is that things are going kind of okay, maybe even getting better. And then they're not. And then it's really, really bad, right? And so the question is, what's really going on? From the outside looking in, when you're looking at it according to plan, you might be looking at things like number of hospitalizations, number of beds that are occupied. That's from the planner's office, right? What you're not seeing when you're looking at it from kind of the C-level suite is you're looking at what people are actually doing, and you're looking at how hard they're having to work to even keep up with the workload for what's going on.
Yep.
So if you were to know how well the system was adapting, how well they were able to compensate, you would need to be reporting on things that we don't have visibility into. We don't get to see much in terms of what's happening with the doctors and the nurses and the way in which they're running around and the way in which they're taming dragons, right? To use David's analogy.
Right.
We get some evidence of this when we get, we can watch an interview with an Italian doctor who's talking about the things that they've had to do and the way they've adapted and the way, right? But the things that are being reported, I don't think are representative of the actual processes at work on the front lines to know how well we're actually adapting and coping. And so this is the prelude potentially to yet this other pattern from the outside looking in, according to plan, that everything was going according to plan until it wasn't, and then everybody died. For reasons not related to the coronavirus, I actually had an appointment with my own personal care physician yesterday. And his office is right next to our local pediatrician's office, right? And I was talking to the office staff, and his office was really quite calm. The office next door, the pediatric unit, right, was going crazy, right? They had everybody bringing kids in. They had set up kind of a triage thing in the garage where if they thought there was a suspected thing, you could, right? I mean, it's still cold and flu season, right? And kids are out of school and parents are freaking out and, right, there's all kinds of stuff going on, right? We only have 5 confirmed cases in the Monterey County right now.
What are they all taking their kids to the pediatrician for?
I imagine it's cold, flu-like symptoms. I imagine it's cough. I imagine it's, right. I mean, the way in which this virus presents is not unlike other seasonal kinds of things.
Makes sense.
Right. Right. And so if you're a parent, right, it's easy to get worried. If there's anything you're going to get worried about, it's going to be your kids, right? So
that all makes sense too. But they're going to the pediatrician not because of anything that's related to the COVID virus. They're going to the pediatrician because everybody around them is saying panic. The pediatrician ought to be telling them, I mean, yes, look at the kid and the cold and the flu, but we know that their children will not be hospitalized because of COVID. Their children will not require intensive care because of COVID, and their children will not die because of COVID.
So the issue is, I sent you the paper from this week. The study in China found that once they adopted the strict travel restrictions and mobility restrictions in society in that province, almost 80% of the infections following that date were from asymptomatic or very mildly symptomatic. I mean, in hindsight, because
that makes sense. Yeah.
So mildly asymptomatic means you maximize the inability to tell what's going on relative to the run-of-the-mill mix of problems people have seasonally. So these are people who are transmitting the disease. And let's go back to the fundamentals of epidemiology. If you don't get the transmission rate below 1, you can't not, the outbreak continues indefinitely. The transmission rate must get below 1. So and what's the vector is kids. And if you don't do those to break transmission keeps going up. But depending on how that transmission is going, right, you expose more and more of the vulnerable or comorbid populations requiring more hospitalization.
That makes sense.
Now, this process of the anticipation paradox, right, which is, that's why I say, if you wait for the evidence is definitive, and that's what you keep insisting on, but the evidence isn't definitive. If you wait
I'm not insisting that. Look, there's a guy at Stanford who's written articles that say that, but that's not what I'm saying. I'm saying the evidence is definitive. This is not as fatal as the WHO has estimated. It is much more contagious than the data that we thought, and it is much more mild. It is little or no risk for people less than 50 without comorbidities, and it can be serious for people over than 60 and serious for people with comorbidities. And I'm not saying that that's uncertain. I'm saying we now know enough. We now have definitive information to draw these conclusions. The case fatality rate will not be 1%. 1% is the top possibility, not the bottom. It will be something way less than the Diamond Princess 1%. And the number of people infected will be huge, but those requiring hospitalization will not be.
The numbers I've seen and worked on suggest the difference is between under 1%. We go back to China outside Wuhan, South Korea, Taiwan, Hong Kong, Singapore, all of those places who have controlled the initial outbreak or have nearly controlled the initial outbreak, right? All of those are successes. The outbreak has shifted to keep it from re-flaring up.
Right.
All of those places, except Wuhan, have below 1% fatality. Wuhan has over 4% fatality, right? Italy has well over 4% fatality. And so we can do some modeling to estimate over the long haul as outbreaks persist and whatever. And right now, our rule of thumb estimate would be a factor of 10. If you handle it reactively badly, you'll kill 10 times. Now, when it's all over, and I've said this before in our discussions, I don't know if it was the ones recorded or not, at some point we will be able to make some different kinds of excess death calculations depending on different kinds of comparisons. But these are all well after this is all over. We will understand more about what are the better ways to have worked. We'll understand what was really delayed. We'll understand what interventions were more or less effective. We will recalibrate what we thought was more effective to being less effective, what we thought was less effective to being more effective, and what contextual factors made that vary in different parts of the world, different places where outbreaks happen relative to their societal and vulnerability context. We will fine tune all that. And what there will be, I guarantee it, is a significant number of excess deaths in several of the regional outbreaks around the world. Why do I know that? A, because it happened in 1918. B, it happened in Wuhan. C, it happens in Italy for this virus. So we know today that if you're aggressive in building your response capability, if you're aggressive at reducing transmission below 1, you have an outcome difference. This is a case where we have the statistics on linking process to outcome. And right now, our early estimate is 10 times. So if you don't take it seriously, if you don't act aggressively to cut transmission, if you don't act aggressively to build response capability before your hospital is crowded, you can currently expect a 10-fold increase in fatalities. Right? That's where we stand right now. Now, maybe that's 8-fold. Maybe it's 6-fold.
No. I think you're making total sense. Because in the previous influenza epidemics in Italy, not coronavirus, just the 2016, 2017 season, go back a couple of years earlier, 2013, or maybe it's 2014, 2015, 44,000 people dead. 10 times the death total of COVID. And you have convinced me that the quarantine and the isolation and the measures that they put in place to reduce the rates of transmission, as well as the ER and ICU innovation that they've implemented in the Italian hospitals, and the nurses and the doctors working their asses off, has reduced the excess death rate in response to this pandemic. Because I'm looking at data that says 10 times more people died a couple of years ago in a seasonal flu outbreak when they didn't take those measures. So yes, now, do I want to shut down the state of California because I can save those people? I do think that's a legitimate policy question. The lawmakers, the executive branch of the state of California said, yes, we're going to shelter in place for 3 weeks. I don't see that as being a worthwhile policy prescription.
I mean, I said it before, and this is basic epidemiology. If you can't test enough, right, the standard way is test, find, right, and a lot of times you have this surrogate for testing because the illness is unique enough and severe enough that people present, right, at medical facilities. So you don't have to have a screening test, or you may have a confirmatory test, and you may have some milder cases you need to identify. But basically, you identify who's been infected, you trace who they've been in contact with, you isolate in order to break transmission, to drive the transmission rate below 1. That, if you don't do that, it just keeps growing. And if a percentage of those requires hospitalization or intensive hospitalization care, then you grow the numbers that can overwhelm a system. And you have to grow capability to handle those growing rate because the numbers of infected keep going. And so it's basic. You have to break it. If you can't test, the only other thing to do is stop people interacting. You stop people interacting. Now, we will certainly be able to go back in Wuhan province and say, down the road, we'll get all the data, we'll be able to do all the analyses and come back and say, what interventions to social distance, stop travel, lock down people and break up normal life, what degree of effectiveness did they have in bringing down the transmission rate? Right? We know in advance of this that testing, tracking, tracing, and isolating is effective. How much some of these other things are effective is, and to what degree and in what social and political context varies. We know if you get lots of people.
I love test, track, isolate. And so you get no argument from me there. It's too late to do what Singapore did. Comprehensive testing, tracking, isolating. It's too late to do what South Korea did. And that doesn't change the fact that I agree with you on test, track, isolate.
So in the absence of being able to do that, the only thing left to do is to do these more draconian kinds of isolation and shutdowns too.
I disagree with that. In the absence of test, track, isolate, we got to learn as much as we can without testing because we're not testing. How do we learn as much as we can about the rate of transmission and about the progression from symptomatic to requiring hospitalization, to requiring intensive care, to death? The way we learn about that is by looking into the hospitals and seeing how does that progress. it's been 10 days. And we're not seeing the rate of progression that would justify the draconian measures.
So you're correct. There is information in the hospitals or in healthcare facilities as they see people. However, those are very quite simply, this is in the history of system safety, we call them very simply lagging indicators. In other words, by the time you start to see those ramp up, you are already in the surge. You are already well into it.
Right.
And your ability to scale up is, if you haven't already scaled up, you're screwed. Now remember, we talked at the beginning, the very first practice one that did get recorded, that afterwards you can go back and identify how you were, that you over-prepared in some places or in some ways or in some regions.
Correct.
As things go, because we don't know everything in advance.
And I'm not arguing that we shouldn't make the deploy decisions, the mobilize decisions. Let's get the ventilators. Let's build the infrastructure. What I'm saying is Wuhan has had no new cases. And you could say it's no new cases because they have implemented these draconian measures of distancing and isolation and quarantine. There is an alternative explanation. And the alternative explanation is that Wuhan's curve went exactly through the curve that you would expect if it was highly contagious and just not that deadly. In other words, they're not getting new cases because the people who were going to be infected have been infected. They haven't flattened their curve. They have truncated their curve. If it was a flat curve, we would expect to still see new cases showing up. If the curve is truncated, it's because they have created immunity. And the immunity is being created by the antibodies that are in the people who have been exposed. That's an alternative explanation to the curve that we're seeing in Wuhan. Unless I misunderstand my fundamental
well, I guess
epidemiology.
the question though, Tom, that in Wuhan, they're still on lockdown, right?
I don't know what they are, but let's say that they are, yes.
Let's say that they are, right? So you've got these two hypotheses, right, that potentially explain what's going on, right?
Right.
I think that your argument would have stronger appeal if in Wuhan they had relaxed this isolation, that if business had gone back to normal and there were no new flare-ups, right?
It would be stronger. Yeah, that's what we would expect.
Because it's also quite possible that, you're not seeing new cases because they've locked everything down and there is no more transmission happening, right? And the moment that they rescind these lockdown measures, right, if you start to see flare-ups again, right? And then, but again, unfortunately, then you're in the middle of another outbreak, right? So,
right. Well, we've seen this. Hang on, no.
The hypotheses don't hold up as equivalent, right? And
this is the graph that we've all seen comparing Philadelphia and St. Louis. This is the graph that is the evidence for flattening the curve. The 1918, Philadelphia held their parade. Yay, the war is over. St. Louis canceled their parade. This is flattening the curve. Which curve looks like Wuhan? It's not the St. Louis curve. It's the Philadelphia curve. Philadelphia, the infection went rampant through the city, and then it ended. It ended because of the antibodies that were built up, because people became immune after they recovered. St. Louis, the infection did not end because St. Louis flattened their curve by reducing the rate of transmission. The Wuhan curve looks more like the Philadelphia than it does like the St. Louis, which is why I'm putting out this alternative hypothesis.
But the issue is the shifting from this very high level population coarse-grained look and looking at what kinds of actions can happen on the ground. In the Wuhan case, as far as we know from all the things happening across the successful containments in Asia is it's driven by testing. And that limits the comparison to 1918 because of the inadequate ability to test and understand and do these other kinds of interventions.
That makes sense.
And so in this case, there is plenty of evidence that actions that were taken, and there's plenty of actual evidence that the testing regime was the big driver of dropping transmission rate, and not so much the social isolation. The social isolation helps, but is not nearly as effective, or certainly not as effective by itself, which is the worry on the U.S. side. And the answer here, and that's why I keep coming back to these issues, or the way I've written up why the sacrifice judgment is so hard to make. To sacrifice normality and productivity in the usual way we do things when you're confronting this mismatch, right? This growing mismatch as things challenge the boundaries of that normal activity and processes and productivity, is we don't know yet. So afterwards, we will know, right? And then you're in the middle of it, you need to do something. Responsibility requires action in the face of the challenge to mitigate the challenge. That's fundamental responsibility. And and every aspect of society needs to find a way to think about how they contribute to that. Otherwise, what you're doing is you're taking all the cleaners and other people who have to keep going so that essential supplies can move around, and all of the healthcare workers, and you're throwing them to the wolves and saying, somehow make it work, and we don't care how bad you suffer. We don't care the casualties or losses or PTSD you suffer from having to go through this crisis on the front lines. The rest of us will sit back and try to minimize the variation on everyday life.
You know that we do care. You, I, and Dave Alderson all care. And right now, the healthcare workers in Maricopa County, in Arizona, where Phoenix is located, are having to deal with the grand total of 10 people hospitalized for COVID. And they're doing a fantastic job because none of those 10 people who are hospitalized for COVID in my city of like 4.5 million people have died. Thank goodness they're all still alive. When can I expect a surge? I mean, is it going to be a week, or is it 2 weeks? Or after 3 weeks, do I say, "Oh, that worked great. Thank God that's over"?
So you brought up two things there that I did want to talk about. Right, one is the people doing the estimating are not doing a good job of helping. We've seen some glimmers and better than glimmers.
Yeah.
Helping you say what's the evidence that allows you to estimate when and how surges are coming without waiting for the hospital counts, right? And that's important. And I have, another professor and I have our team looking at that here, trying to look at this and show people how you would integrate the different sources of indicators, classic system safety stuff. What are the sources of indicators? How do you put them together? Again,
I think your overload calculator is critically important. We badly need a good overload calculator. Yeah.
Right. And then, so we're trying to look at that and help with that anticipatory part of things. The second thing, and what I sent around this morning, is the coping with attrition. And we can use it as attrition, or we can use it as replenishment on supplies. And again, this is one of the warning signals that it may not take many to overload, because there's certain critical points that will undermine the response and increase the excess illness and death, or the poor care, or less than ideal care risk. And those we see that in particular with protective gear. We see it with the limiting testing. Yesterday's press conference said Ohio has 1,500 serviceable test kits. All of Ohio has 1,500.
That sounds pathetic.
And so the protective gear warnings of shortages in the UK, shortages in New York, Ohio 3 days ago were understood that they did not have enough. and was acting to conserve it, trying to use it as appropriate and standard of care for non-COVID-19, while also trying to figure out how are they going to deal with it depending on the kind of surge of COVID-19 patients they might get. And what are they trying to do? They're trying to hedge on how, maintain some supply so that they can have something deployable as challenge might come at them. If transmission rate goes down dramatically, quickly from the interventions that have been taken aggressively in Ohio, then you would potentially be, hey, we made it through, or we were able to do some basic supplementing and carefulness and reuse and things to get through what could otherwise be a shortage. But that to me is just a indicator of a fundamental issue in these, which is first, how do you sustain performance, right? How do you deal with attrition of supplies? You use up supplies. This is common in military planning, and it's common in command experience that your model for resupply, replenishment, coping with attrition, A, you'll have more attrition than you think you're going to have. B, your resupply won't be as effective or targeted as it turns out you need, right? And too often it ends up that the frontline people just have to sort of make do under tremendously limited circumstances. Preparedness is essential from all that we know about epidemics threatening to spread dramatically and more across trained populations. We would expect at the end to have a assessment that says we built up preparatory capabilities that we didn't need. Right?
Which would be great.
Some people will say that.
Fine with that, yeah.
Right? But it's actually a sign of success. If you build up capability you didn't use, you succeeded. So how do we help people think through the attrition and replenishment, whether those are physical, but also the personnel issues? Now, it's hard for people preparing for a crunch, right? Or people in a crunch trying to survive it and do the best possible while in a crunch to think about the next step or two.
Sure.
But that's the other levels of society, the other kinds of organizations at a distance from the front lines should be working to help the people at the front lines by saying, how do we replenish? How do we fight attrition? How do we help the people who are getting fatigued and exhausted? That's a battle yet to come. Now, I don't know what that looks like in Wuhan. I don't know if people would go in automatically from a medical epidemiology, infectious disease point of view, study that. But that would be an important thing to understand more because they're far ahead in this as they've moved to a post-outbreak, prevent it flaring up again, and relaxing some of the restrictions. I don't know how far they've relaxed them, but they've relaxed everyday life things somewhat. And they're trying to prevent a flare-up, and their ability to relax restrictions and prevent flare-ups is related back to testing. That's why testing at scale will continue for ages.
I hope so.
2 years from now, you're going to get, we'll see exactly how it works out when, but as this resolves, you're going to get tested before you get on a plane, or you're going to get tested when you get off a plane, hopefully before you get on the plane. Large-scale testing will be ubiquitous until we have treatment options that we know work and we have preventative options that we know work. Right now, we don't have either of those. And so that's where some of the estimates come in, which is until we can have those at scale, we're going to have quite a bit of these other measures because they're the only ones we have to take to limit the effects and the potential lethality for parts of the population. But I think we should be able to think about ways we could help them on this attrition end and on how you sensibly stand down what information you need to slowly roll back what kinds of measures. I think what you were pushing on in terms of society interventions to break transmission that are, kind of coarse-grained, kind of shotgun to do this because that's the only tool available. I think the way we would solve what you're bringing up is not on the front end, not on, if these seem to be overkill, get back to great. The place we need to focus on what you brought up is on the resolution, right? Which is how do we roll back these restrictions in a sensible, safe way when we have contained, right, the transmission and when we've broken the transmission, got it below 1, and we have sufficient healthcare capacity that's sustainable to deal with the seriously ill people as a result, as well as all the other illnesses that normally occur through the season. If the healthcare treatment is under control and transmission is broken, we now need to be sensible about how we roll that back. And that's the immediate post-outbreak phase that I tried to point to. Now, here's the next problem we've talked about. This is a rolling outbreak. And when you have a continental jurisdiction like the United States, the timing of where outbreaks will happen across the regions and rural, urban, et cetera, will vary in time. So that while Washington State may be in a rollback as the first one to get hit and slammed, they may have contained transmission. They may have generated enough medical capacity to start rolling back some of the other societal interventions. They're going to have a limit in their ability to do that because outbreaks will start happening in other parts of the country. And as those grow and threaten and require intervention to break the transmission process, that increases the kind of undefined risk of reflaring up in an area that already experienced the outbreak cycle, such as Washington. And so that's what I think is a little more difficult for us, right? For Europe, where you have a variety of political jurisdictions, the ability for Italy to relax, that it's solved, it's brought transmission down, generated enough sustainable medical capacity, can says, oh, wait a minute, well, we can't open borders to places where the outbreak is still growing, right? But we can start to relax the social isolation kinds of things within our territory or within parts of our territory as this we move into the resolution of the outbreak phase.
Right.
Where the immune response, to me, if in the end, the only solution is immune response, vaccination, annual retargeting of vaccinations to tailor the change in the virus as it becomes part of the sequence of viruses we have to worry about, but that we could bring down the fatality rate from treatment from people who do get it as well. But those are all long-term. And so it is possible that we will turn back and look around and say all of these had minimal effect because it was only the long-range ones that mattered. I view that as defeatist and a kind of pessimism that is unwarranted and dangerous. And that is just as the frontline workers have that to carry out and assume their responsibility to try to mitigate, right, and help people recover with the tools at hand at this stage. That's why I broke it into these 3 parts. How do you get stop the outbreak, right? And our 2-rate approach. How do you resist flare-ups and support the replenishment and nutrition phase, moving into getting this under control, where you can now focus on not getting new flare-ups and new outbreaks recurring in areas that already had an outbreak. And then how do we move into a transition into a long run where we start to build up new tools for building and facilitating immunity to reduce the number of infected in the long run, as well as the treatment options.
Dave Alderson, other observations? And I ask this as kind of a last word.
Going back to some of your provocative statements at the beginning, right? So one, Tom, you drew a picture that said that, what happened in Hubei province, right, in Wuhan is more like Philadelphia than it is St. Louis. but your cartoon completely lacks scale, right? The scale in Philadelphia was tens of thousands, right? 150, 200,000 people, right? So Hubei is like 3,000 people, right? Who died?
Wait a minute, what?
Hubei, Wuhan, it's like 3,000 deaths.
Okay. Right, it's a city of 11 million people. Yeah, and
the region is like
something. That sounds right.
But the region is like 57 million people, right?
Wow.
And if you were to say that out of potentially 60 million people, it raced through the population and 3,000 people died, that truly would be like, maybe that's not such a big deal.
Right.
What I think happened is that you saw this dramatic increase and they locked everything down, right? Yeah. Maybe not as quickly as they should have. But I think that if we were to actually get, information about where these infections were and whatnot, right, you would have pretty strong evidence that this did not race through the population and flare out. That in fact they locked it down, and that having not done so would have led to a much more dramatic, much more, right? Everything would have been much, 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 much worse, right? So I find your explanation that, who's to say? Maybe it really just raced through the population and the things that they did weren't really effective. I find that pretty implausible on a whole number of levels, right? Right. So I mean, that's just one statement, and we don't need to go into sort of dissecting this alternate hypothesis testing, but I'll just say for the record, I find that explanation implausible. Okay. But the other thing that you said at the beginning, which was fairly provocative, that was really more about policy decisions, right? And the governor of California, right, who is taking these draconian measures to lock down the state, and this is not whether or not this is a reasonable response, right? So in both cases, what's a reasonable response? You could look at kind of like from a cost and benefit standpoint, at least simplistically, right? And your statement that it's unreasonable makes all kinds of assumptions about what the actual costs are here, right? Now, we have a sense that forcing people to shelter in place is going to have all kinds of really bad economic ripple effects in terms of, particularly for people who live paycheck to paycheck and are hourly and all kinds of these other things. But we're making the same kind of speculative arguments there as we are about the virus racing through the population, right? So for us to start to get into that kind of a discussion, right, requires some more thoughtful conversation than we've had here.
That's really good, Dave.
Right. So the question, I mean, what's sort of an interesting, if we want to think about this and maybe talk about competing rates on a different way, right? You've sort of got two different viral propagation kinds of things, right? You have the virus itself and the public health propagation, right? And what it means in terms of reproductive rates and transmission and the ability to lock it down, right? And yet you've got this other side, which is this propagation through the economy, right? So that is to say the economy is required, essentially is built on continuous rates of flow of cash through to people who go out and consume things and buy things and businesses, right? And so the same measures that are being put into place, right? Because we can't appropriately test, trace, and isolate, right? We're putting in measures that are going to reduce the transmission rate of the public health concerns for the virus, but we're also reducing sort of the economic transmission rates, at least locally, right? We're all buying things like crazy on Amazon, and UPS and the US Postal System are both very busy right now, right? But there's this concern that this is going to have these sort of rippling effects on the economy. And so we recognize that both of these things are real and they can happen. And to have a thoughtful conversation about them, we would need to do more, right? More than just say, I think it's unreasonable, because what is within reason is we haven't gotten into any of those details.